So I'd like to welcome everyone here for our 21st annual meeting. And this is the first time in 3 years where we've had in-person venue. So it's good to see some people. Also, I'd like to welcome, so first off, we have a couple of American Sign Language interpreters, Jude Anderson-Poots, and then Tammy Thibert, who will be also assisting with the presentations. And so the first speaker today is Dr. Mary Jenkins, and she's going to be talking about movement disorders, a sort of case-based program. And Mary's been with us before, and we've had lots of excellent presentation. So Mary is a associate professor in the Department of Neurological Sciences at Western. She completed her residency at Western and did a 2-year fellowship in training in movement disorders. The first year was at Western, and the second year was at the University of Rochester. She specializes in both adult and pediatric movement disorders, including Parkinson's, Tourette's, and other movement disorders. Her main research interests are in the field of movement disorders, including Parkinson's, and her focus is on motor control and encompasses human studies of gait, posture, upper limb control, and speech and cognition. So welcome, Dr. Jenkins.
Thank you very much. Thank you very much for, I'm not sure where I'm looking. I'll just look straight ahead. Wherever you like. Thank you. Thank you very much for inviting me again to present. I was here not that long ago, so I tried to choose some different topics than I had reviewed last time. Some are with adults and some are with pediatrics. Feel free to ask questions as we go, or certainly at the end to ask questions. I have no conflicts, and so I wanted to review cases, talk about approach, and then talk about some management strategies, things I do. So the first case is a 40-year-old woman who was referred actually to a colleague of mine with hand turning and head nodding movements, and I'll show you the video. They started in very early childhood, probably about 2 or 3 years of age, and have stayed the same. They occur whenever something very exciting or very funny or very interesting is occurring, and also at times when she's stressed or bored. They occur daily, multiple times a day, and if you ask her to stop them, she can stop them immediately, or if you were to hand her something, they would stop immediately. So I'm just going to show you this slide. I have this sound turned off, but I'll just, she's chatting to 2 people and they're asking her how she's doing, and then they're asking her something that she likes to do. So these are the movements, these hand flapping bilateral movements. There's a little bit of a lag on the video, so I apologize for that, but it's these large amplitude hand flapping occur when she's particularly happy. As they ask her things and she starts to talk, then you see her hands come back down again. They aren't terribly bothersome to her. Thoughts on what these might be? If anyone wants to yell out things, or if there's somebody in the, I can't really see the chat. I don't know if you're able to. Chat.
Overflow movements?
Overflow, sure. Yeah. Any other words that we use for those? Yeah, overflow is a good word. Stereotypies, yeah. So these are pretty typical of stereotypies, depending on where you're from. Some people call them stereotypies and some people call them stereotypies, but they're the same thing. And so they tend to be these pattern, usually bilateral, episodic, purposeless movements, and common ones are hand flapping, hand turning, head nodding, body rocking, and they tend to remain constant over time. Usually they will start at a very early age. They think before 3. They're very easy to distract people out of them. As we talked about, they occur when people are particularly excited. They're a version of a, for lack of a better word, happy dance. You enjoy doing them. There's no urge. They aren't bothersome. They aren't uncomfortable, and they tend to persist through life, but you don't always see them. So I have some children I've seen with stereotypies, and in talking to the parents, one of the parents says, "Oh, I do those," and no one's ever seen them because they've toned them down to the point that they're just very, very small movements, and they, you know, they like to do them when they're particularly happy or excited. They occur in children and adults, as I said, who have developed mental issues, autism, but also normal intellect. They have a higher rate of comorbid association with tics, ADHD, anxiety, obsessive compulsive disorder, and a family history. Treatment, so Harvey Singer, who's a pediatric movement person in the States, has written a lot about treatment of stereotypies using a habit reversal training. The question always is do they need treatment? And I think often family members are more concerned about them than the person who's doing them, because socially, I think people are often concerned. They're concerned about what other people will do. So he has talked about using habit reversal, somewhat similar to what's done with tics, that they have to be aware of the movement and suppress them. I had one child that we kind of talked about doing that. They read it, they tried it. She did not like it. She was really mad because she wanted to do these movements and she couldn't. I saw her when she was maybe about 17 or 18, and she used to do sort of this very large amplitude bilateral hand movement, and she now does teeny ones when she's very happy or excited, but didn't want to stop doing them and was bothered by us trying to stop her. So it's always a question, I think, because socially people view them as being a concern, but they are an expression of somebody's feelings. So it's hard to necessarily stop that easily. So any questions about stereotypies? Any comments on other people? I know all of you have probably seen these. I don't know if you have ever other comments about things you found that worked or didn't, or. I will move on, but if there's questions, let me know. This is a 15-year-old girl who's had these generalized movements from birth. Also has a delay. She had a normal birth, and at 4 months couldn't learn how to roll. Started to get tight fisting in her hands, and her tone increased over the first 2 years of life, and had remained at that level. And this is a video of her, and I had sound, but we can't do that. So I've just asked her name. So as I asked her name, and her hands came up, and she's telling me that her name's Patty. And I've asked her to spell her name, and it's very effortful for her to speak, so it takes a while, but she's spelling her name as her hands are coming up. And I think she's done spelling, and then I've asked her, can she bring her hands up, and then can she bring her hands down? And you see that the pattern of the movement changes. So sometimes it's straight, sometimes she's bent, sometimes one arm is bent and the other is straight. So variable postures, which is typical of this type of movement disorder. So thoughts on what this movement disorder is called?
Spastic cerebral palsy, or like something to do with cerebral palsy?
It is to do with cerebral palsy often, but it's called a dystonia. So, at one time we always thought cerebral palsy had to be either spastic or choreiform, like all different terms. So there's an understanding now that often, especially in the arms, there's a lot of dystonia. So if you get her relaxed, her tone's actually normal in the arm. So she doesn't have any spastic tone, but anytime she's activated, then she gets these very high tone. And dystonia tends to be perhaps more difficult or different age to treat than spastic tone. And
Mary, what does the word dystonia actually mean?
well, there you go.
Oh.
Thank you. I was just frozen there. So it's the involuntary muscle contractions causing a twisting movement or an abnormal posture is how we define it. What it is, from the standpoint of the muscles, is you get co-contraction of agonist and antagonist causing these abnormal postures and the twisting. When they do functional MRI scans of the brain, they can see that there's an overactivation of the area of the brain. So if I'm going to move my arm, there'll be a small part of my brain lights up as I'm moving it. When people have dystonia and they go to move it, it lights up a very large area of the brain. Sometimes even the other side becomes activated. And that's with movement of that arm, with movement of the other side, with speech, any kind of effort, any kind of activation brings it on. So there's a million different causes. Childhood onset is a particular type. The hereditary autosomal dominant are the most common. This something called DYG1 torsion 1A, which is an autosomal dominant hereditary dystonia, starts in a leg, generalizes over about 4 or 5 years, and then stays at that level. The second one isn't as common, but I wanted to bring it forward. It's called dopa responsive dystonia, and it can look just like CP, exactly like cerebral palsy, but it's very, very treatable. Low dose levodopa treats it. So I saw someone not that long ago who was 17 and was told that she had CP on half her body, involving her leg. It didn't quite fit. We started her on a tablet of levodopa a day, and the tone's totally normal. And she's functioning, she's having difficulties. So they're often missed. So anytime you see anyone with a dystonia, it's important to trial levodopa because it can be curative. And we think even up to 40 years of age, it's still worthwhile trying because it's quite a variable presentation. So this girl probably has a perinatal hypoxia, so as you said, cerebral palsy. Medications also can cause a dystonia, more commonly of the trunk, certain toxins rarely, and then certain structural lesions as well. Yes.
So then is dystonia and people taking antipsychotics, it's considered an extrapyramidal symptom,
Yes.
but would be the same cause as tremors?
It's yeah, similar type of thing. Yes. The tremors tend to go away when you stop the medication.
Yeah.
The dystonia may or may not go away, so it can become chronic. Yeah.
Because also I think, well, back when I was seeing more people with schizophrenia, I see people with acute dystonia where their sort of eyes they would describe as rolling back.
That's an acute reaction.
And I'd always assumed that it was a fixed thing, but a patient recently told me that no, that it wasn't that his eyes stayed there and got stuck, but they would sort of slowly roll back and he could move them a bit,
Yeah,
but not much.
Yeah.
It was a problem obviously when he was driving. But what I was surprised, he said there was enough time for him when it started that he could actually pull his car to the side of the road and then call his mom or something like that to come in.
Yeah, and usually there's a trigger for the dystonia, like stress or something's happened or they're having to move quickly that will bring it on stronger. And I haven't really talked about, I'll just finish this and then I'll come back. So certainly there's a lot of hereditary diseases that can have dystonia as part of it. So Wilson's, Huntington's in adults. Parkinson's and the atypical Parkinsonism, particularly things like progressive supranuclear palsy, we see it. And then some of the degenerative disorders. What I didn't talk about is because it's less in the world of disabilities, but people when they're adults can get a focal, like a neck turning dystonia and writer's cramp dystonia. Those are quite common. So treatment is if you're only treating one limb, and obviously for this woman that I've presented, you can't only treat one limb. But if you're trying to target a foot or limb, Botox is very, very effective. Not a lot of side effects with that, and will reduce the tone well. If it's more generalized, then levodopa we're always trying anyway, as I said, because of the dopa responsive dystonia. Trihexyphenidyl has been studied for dystonia. Baclofen is used more for spastic tone, but also has some effect on dystonia too. And then intrathecal baclofen, so just a different way of giving it. Deep brain stimulation surgery is helpful. We know for the primary dystonias, we don't know as much about secondary causes. One of the problems, obviously, if they're doing surgery on the brain, is there's consequences for that. So in the adult world of Parkinson's, we know that if someone has cognitive issues and we do deep brain stim, that it will worsen the cognitive issues. So that's always a concern if there is any. So she was, what I was going to say is, we actually, she didn't speak hardly at all. And we started her on levodopa and she started talking. And I think it was because it just relaxed the muscles. So what levodopa does is it just reduces some of the co-contraction. It didn't really improve her arm tone or her leg tone, but it did improve her speech. And she started talking, and I still follow her. And I think she's now, I don't know, I'm going to age myself, but maybe 28. And her mom said, you know what, I want to try to take her off the levodopa. And I said, well, let's try. We'll see if it changes anything. So they took her off it, and her speech is still stayed. So, you know, my own theory on it is that it's just, it relaxes the muscles, it becomes easier to speak, and then I think she feels comfortable.
Wouldn't her muscles have tightened back up without the levodopa?
Well, they would, but I think she had learned how to speak and was just able to still be able, I think it probably took her more work, but once she'd kind of reached that, how she just, you know, started to speak and just wanted to keep speaking. So I think as a child, it was just so hard that she didn't bother. But I think once she figured out how to do it, then she was still able to speak, even though it was probably harder for her to do that. And it was very interesting. I mean, you know, we didn't know what her cognitive abilities were, but she was able to spell her name. She was able to tell you her address, like lots of things that we thought she couldn't actually do because she couldn't speak before. So it did open up a bit. Okay, this is a 40-year-old who presents with some involuntary movements. These started a couple of years ago and have worsened. She is underlying schizophrenic, and schizophrenia, and was on aripiprazole or Abilify for that, and didn't have any family history of anything. And you guys may have seen this one before. So what are we going to call these type of movements? Chorea? Yeah, these are Chorea. So Chorea-form movements and possible etiologies for her. Huntington's is a good possibility. So, you know, we wonder, is it a side effect of the aripiprazole, so tardive, or is it Huntington's? Hers has turned out to be tardive, but we've had the reverse happen where we assumed something was tardive and actually they had an underlying diagnosis of Huntington's. So always keep, you know, always good to be aware of that. Chorea is a dance-like movement, so it's much more kind of chaotic, flowing, semi-purposeful. Sometimes people will, as they're doing movements, kind of blend it into like pushing hair behind their ear or putting something in their pocket, or very dance-like movement. So I just want to talk a little bit about tardive dyskinesia, not antipsychotic induced. Yes, it was antipsychotic. It was from the era of Beprazole. So tardive dyskinesia, medication-induced movement disorder that is still present a month after you stop the medication. Typically, we think about it as being mouth and tongue involvement, but as you said, with her, other body parts can be involved. And you can't tell looking at them if it's Huntington's or if it's medication. We saw a very tragic story, but a 19-year-old girl with no family history of Huntington's, who had psychosis, treated with an antipsychotic, started to get movements. We assumed, especially because there was no family history of young woman, that it was all tardive, but it actually turned out that it was the start of her Huntington's and that there was a family history. So good to think about that. So tardive dyskinesia, we're learning more about it, but boy, we don't know much about it. So certain people seem to be at risk. We think there's some genes that put people at risk. Certainly having any underlying brain damage puts you at a greater risk of developing tardive syndromes. It's slightly higher in women, and especially as people get older. And anticholinergics seem to be associated with a higher risk, although that may have to do with the dose of the neuroleptic. So these are all associations, right? We're still learning about all of that. And it's not just antipsychotics or neuroleptics that can cause tardive syndrome. Parkinson's medication, antiemetic stimulants, methylphenidate, antidepressants, some of the anti-seizure medications, the monoamine oxidase inhibitors. So a number of other medications have been implicated, less commonly, but just to be aware that there are other causes.
I realize we don't really know much about how these things happen, but given that stimulants essentially do the opposite of what antipsychotics do,
I know.
how do you explain that?
Well, Parkinson's medications do the opposite too. So it's very badly understood. The theory I've heard is it's not that the basal ganglia is upregulated or downregulated. It's a change in the firing pattern that can lead to it. But again, not well understood at all. That'll be my book.
There you go, waiting for that one.
Sort that out. Prevalence is probably about 15 to 20% higher with typicals than atypicals, as everyone knows. And it doesn't seem to matter if they're receiving the medication intermittently or continuously, although the higher the dose, the longer that you're on it, the greater the risk. And as I said, lack of trials about treatment. Obviously, withdrawing or changing the neuroleptic, clozapine, which has its own problems, does not seem to be associated with any tardive syndrome. Quetiapine, Seroquel also. There's a couple of very small, not well done trials that have talked about vitamin E as being potentially helpful. Tetrabenazine is the drug that has been quite effective. The problem is, I don't know if you've obviously used tetrabenazine at some point.
Once or twice, yeah.
So tetrabenazine is it works well to reduce the movement problem, but it has other issues. So it can worsen anxiety, worsen depression, worsen OCD. So it's a drug that we use very cautiously, right? If we're working with someone who has mental health issues, then we have to be quite careful. Having said that, boy, I was much more cautious about even trialing it, and I haven't and using it more often and getting some good responses. So something to think about. Very low dose. Botulinum toxin can be used if it's only a neck problem or a localized problem, and then small trials with the entity. Okay, so this is, how am I doing for time? Am I?
We're good.
Okay.
We're good.
This is a 75-year-old. This is not a big surprise, but I just wanted to talk a little bit about this one. A 25-year-old with a 2-year history of tremor, difficulty getting up out of a chair, quiet speech, low mood, some difficulty doing fine motor tasks like buttons, and trouble with gait, and I'll show you her. So she has bilateral hand tremor. And I'm not sure it comes out quite as well on the Zoom, but bilateral leg tremor, trust me on that, occurring at rest. Certainly a lack of spontaneous movement. I've just asked her to bring her hands up, and the tremor stops when she elevates her hands. I'm just gonna zoom along because she's doing a bunch. She does some tapping and some slow, rapid, alternating movements, and then I'll just get to her. I always wish that I'd done the follow-up video on her because it's so small steps, so quite slow in the small steps. Thoughts about her? Parkinson's, yeah. So she has Parkinson's, adult onset. I don't have a video of I follow some people who have Parkinsonism or Parkinson's, and so we think of Parkinson's can be idiopathic, or it also can be medication induced, so tremor, slowness of movement. I wanted to bring it up because I have some people I follow, actually one guy that I'm following very closely right now who probably has Parkinson's and also medication induced. So he's been on Haldol for years and is coming off Haldol, and we're switching to clozapine, and it's a real puzzle about what's going on. So that's a common thing. And then the other is I have some people who have Parkinson's. It's common, 1% of people over 65 who also have cognitive issues, and it's a different challenge dealing with them because it's our treatments are symptomatic. We rely on people to tell us how they're doing. Are they improving? Side effects can be psychosis. How do we manage that? So Parkinson's is, we think of it as slowness plus one of rest tremor, rigidity, stiffness, or balance issues. We have to make sure secondary causes are excluded. And typically in Parkinson's, it will start on one side and then progress to the other. If we think about secondary Parkinson's, in particular medication induced, that tends to occur on both sides equally. There's also more trunk involvement, more axial involvement, where on Parkinson's, where idiopathic Parkinson's is more limb involvement. People with medication-induced Parkinsonism have a poor response to levodopa, but they may have a partial response. And it's more common that the tremor is a postural when you hold your hands out than a tremor rest. And as I said, quite common. Treatment is really still at this stage. We think we would know more about Parkinson's by now than we do, but it's still a symptomatic treatment. So very much relying on the patient to tell us how well the medication is working and how it's affecting them. Levodopa, carbidopa still our most common treatment. It was developed in 1961, and we don't have anything better yet. So that's where the world of Parkinson's is. So lots of room for things to improve. Dopamine agonists also can be used, like propranolol,
Can you call me
pramipexole, brigantine.
Yeah.
And then these other drugs on the other side, monoamine oxidase inhibitors, nantidine, anticholinergics are used less likely, less commonly because of the side effect profile, and they tend to be not as effective. So the mainstay of our treatment are the things on the right. Treatment, ironically, the treatment helps the slowness and the stiffness, but has less impact on the tremor. So often I see people, we start them on treatment, they come back, they say, well, I know better, I still have the tremor, and it's, so we have to explain that it often doesn't help tremor, it helps more with walking, getting up out of a chair, doing things with your hands. Doesn't help freezing of gait where your feet are stuck to the floor. It doesn't have any impact really on balance other than you're able to respond better, and has no positive impact on cognitive issues. Okay, this is my last one. I couldn't not do this with Rob here. 10-year-old with head jerking movement and vocalizations. You know what it is, right? So we started about 3 years ago. So he was 10, started when he was 7. Some of the movements have changed over time, but others have seen the same. Worst when he's under stress, has some mild cognitive issues. Now he's eating and talking here. I'll kind of get to the end when I was just talking to his friend, and when he comes back, he has these sort of a little sort of jerking movement, and he'll do often, I think he's going to do it right now, like a few of them in a row, which was what was concerning for people. So these very kind of recurrent head nodding type of movements, and then carry on. Thoughts what this might be? Rob, do you want to tackle this one? Have you seen these people?
I wonder if it's a tick.
It's a tick. So, other things to think about, because we talked about stereotypies. I mean, these are head nodding. Could these be stereotypies? Could these be, he was actually referred to us with the question of seizures, because he was doing these like really very stereotype repetitive movement, and the concern is he was having small focal seizures, and it can be, seizures can look like tics, tics can look like seizures. So tics are also stereotyped, they're intermittent, but they tend to change over time. So that's a good history to get from somebody. They're usually, not always, preceded by a premonitory urge, although children under 10 generally can't tell you that they have the urge. They can suppress them though. So if you're evaluating them, you can see that the tics stop when they're engaged, when they're doing something. They tend to wax and wane. They usually change in character over time. And unlike stereotypies that people like to do, tics people generally don't like to do. So they're uncomfortable, they're bothersome, they want to get rid of them. They can occur in sleep, which is an odd thing because we think of them as having a voluntary component, and they run in families, but the exact inheritance pattern is in. About half of people that have tics will have ADHD, about half of them will have OCD, about 15–20%, depending on who can have impulse control behaviors, rage attacks, and anxiety occurs in a smaller number, but still a good portion of people, 20%. It peaks usually at about 10 to 12 years of age, and usually as people get older, they will reduce or become less bothersome. In about 5 to 10% of people, they may continue to be impairing, and I do follow adults and children with tics. The interesting thing about adults is often they come to me, they've had tics all of their life, and they've never gone to see anybody about them, and they're now 40 and they're coming to see me because the tics have worsened, and there's almost always a stressor. So they've lost a job, they've split up with their spouse, they're having some kind of stressor that has brought out the tics. And for adults, the treatment often is to deal with the stress or the anxiety rather than to try and treat the tics. Whereas for children, if we feel that they need treatment, it's more often focused on the tics. The comorbid behaviors tend to carry on through adulthood. So treating is, do we need to treat them? Because if they aren't bothering them, then we don't treat them. So often I have parents bring in children, I'm sure Rob has this happen all the time, and say his tics are really bothering everyone in the family. And it's ask the child, are the tics bothering them? If they aren't bothering them, then we do not want to treat them, right? We only want to treat them if they're bothersome to the person that has them. And whether that's because they're being teased or they're embarrassed or it's causing pain or it's interfering with habit reversal training has as good records as medication. CPRI, as you probably know through the Break Shop, offers the habit reversal training. It's better with children who are obviously able to follow along. Medication-wise, first line recommended by various people are the clonidine, guanfacine, although we know those are weakest drugs, but often we will try them first just because they have fewer side effects. And then second line, atypical antipsychotics, and then third line, typical antipsychotics. There's some studies that say the antipsychotics and the alpha agonists have the same efficacy. I can say that I have never really noticed that myself. I think certainly the alpha agonists do have fewer side effects, but we know they are weaker medications overall. And then other drugs, tetrabenazine has been used. Rob and I tried to do a study of that. We won't go into, we won't bring that up again. People do use clonazepam or baclofen, although really off-label use. Topiramate has occurred in the literature more commonly. Yeah, I don't know if you've used topiramate for tics. No, so I think it's still on a case by case. There's no real evidence for that. Medical marijuana, as you know, is a cure for everything, and so I have a lot of people that want to try medical marijuana to treat tics, and some people say it works and some people say it doesn't. So I don't have an opinion on that, other than I'm skeptical. And then Botox can work particularly if someone has a neck tic and it's a very painful, like a throwing their head back tic. Botox can work. The problem is of course, tics change over time. So that tic may go away and maybe didn't need treatment in the first place. And then deep brain stimulation surgery, so the DBS, like we do for Parkinson's, has been done in isolated cases for tics. We don't know the target. We don't know how effective it is. The recommendation from the Tourette Syndrome Association is if you're thinking of doing that, it should be someone who's 18, first of all, or older, and to have it done at a center, at a Tourette center, where they're then able to follow them, so they can at least gather some information to guide us in the future. So people have used different brain targets. We don't even know what nuclei to use. So I think a lot of us are pretty skeptical about that as a treatment, but it is out there, and there are people who are surgery. And that's my list. So just summary. So we talked about dystonia. Don't forget about, if you see somebody with that under 40, consider a trial of low-dose levodopa, just in case it ends up being tardive dystonia, Chorea, and tardive dyskinesia. Parkinson's we talked about, in particular secondary Parkinsonitis. Parkinsonism, and then tics, Tourette's, and stereotypies. Questions from anyone? Yes, oh, take,
Cassidy has a question.
Dr. Cassidy has a question, uh-oh.
No, it's a good one. Thank you very much. I'm sorry I came in a little bit late. I was just wondering your thoughts on Parkinsonism with use of the antidepressants more so than the antipsychotics. I've seen some literature about different antidepressants that sort of may have higher risk for like extrapyramidal symptoms than others, and I'm curious to know if you've had experience with that.
Antidepressants like SSRIs. I have not seen that. And in fact, when people have Parkinson's and they're having lots of mood issues, when we treat their mood issues, their motor symptoms improve. So I've seen the reverse, or people getting ECT that have very, very bad depression with ECT, their Parkinsonism actually improves. So I have not seen it with the SSRIs, although Abilify often is used for mood, but it's a neuroleptic, yeah.
I was going to comment on a related topic. There's a subclinical serotonin syndrome. So if you
Right, yes.
you have people on an SSRI and they'd say they get a little agitated and they have dementia or whatever, vascular Parkinsonism, and you get add in an antipsychotic, it potentiates the symptoms, so they can become really rigid
And have tremors and high fevers and almost like a neuroleptic malignant syndrome, Yes.
As I recall, there are some congenital syndromes that are associated with some specific tic disorders. You can almost make the diagnosis of the congenital syndrome from the tic disorder, as I recall. I'm not sure about specific ones.
I don't know that. I know certain stereotypies do. So like certain stereotypies goes with like Rett syndrome, but I had not heard about a tic disorder. I don't know if anyone else has heard of that. No, I had heard about it more around the stereotypies, but I'm sure there are syndromes out there.
The other thing that I recall, there was a very prominent member of the American Association on Developmental Disabilities who had a tic disorder. And this tic disorder was a sudden movement of his hand to his groin. And it was very embarrassing. He was aware of it, couldn't stop it. And he was actually a very prominent individual who contributed to the nomenclature of the association. So whenever I hear about tic disorders, I think of this individual. At the break, I'll give you his name.
Yeah, there's a story, I think, currently in the United States at one university or last year, there was a professor or some faculty member who had Tourette syndrome, and unfortunately, I think with vocal tics, they tend to be offensive words a lot of time, and so often his vocal tic was racial epithets. And so one of the people in his class was complaining, so the university didn't really know what to do about who, is it an illness that trumps other things, or does the fact that he was yelling out racial epithets, does students' rights sort of trump his? I think it was a huge sort of conundrum for people what to do in that situation. But you say with Caitlin's question, I saw a guy years ago who had, I think it was either some kind of dystonia or tardive dyskinesia, I can't remember, but it actually developed with ecoclomipramine, was what it was described with. And I remember talking to somebody, and it was pretty clear that he had never had it before taking clomipramine. And I remember nobody really knew what to do about it because he did well with the clomipramine otherwise for OCD stuff. He was sort of really stuck about what to do. And I think it says we don't really know what causes these things.
I think there's a question on.
I know I was reading
So
that.
this is from Dr. Zwanek. She is a psychiatry resident at the University of Ottawa, and she's wondering if you have any guidance on treating dystonias in the context of concurrent primary psychotic disorders that are not induced by antipsychotics.
Yeah, so dystonias is, you said certainly Botox if it's focal, if it's one limb, trihexyphenidyl, which would probably be fairly well tolerated, baclofen. Sometimes people have used benzodiazepines, so those can be used if you want to avoid using levodopa. Dystonia, to be fair, is very hard to treat. So it's not that these medications have a huge impact. They often have a small impact. Deep brain stimulation surgery as well, if it's a primary dystonia can be used.
I often get a question from residents about, at least in one appointment, distinguishing between stereotypies and tics. And I think, as you said, over the long term, you can tell because the stereotypies don't change, the tics do. But on one appointment, or if you see somebody once, how would you distinguish those things?
Yeah, so if the person's able to tell you, if they're able to give a story, stereotypies are they like to do them. So they'll often give you that story, like, why do you do them? Well, I want to do them. Versus the tics is, I have to do them, like I can't stop it. So they have a very different presentation. It is hard to tell because they can both be bilateral, but I think getting that story from them, that they like to do them versus they have to do them.
I was thinking for non-verbal people, I guess what I would like to ask is, so am I correct? In my mind, stereotypies look more voluntary, whereas tics, I realize they're voluntary technically,
Yes,
and tics look involuntary. Is that a reasonable distinction?
Yeah. So I had, when I've done this talk before, I have a fellow who is, has a lot of cognitive issues, and he's maybe 40, and he's got both. So his stereotypies are kind of bilateral, like rubbing his arms or moving his hands like this, whereas tics are often unilateral. They look involuntary and they look intrusive. Yes.
Thinking in the realm of complex motor tics.
Yes.
And trying to distinguish some of those movements from compulsions, like in OCD in a younger child. Again, a similar theme to what Dr. Goldberg was saying. I have a patient who has, her education is very disrupted because of self-pleasuring behavior in the classroom. And currently we're approaching it as a complex motor tic, but it's very difficult to tease apart. She says that there is a voice in her head that tells her to do it, but it seems ego dystonic in that she doesn't want to be doing this in public. And I'm thinking perhaps the initial movement is a tic and then the continuation might be something else, but.
Yeah, so they talk about things being compultics, like a compulsion and a tic, and I think that they are often combined. One of the things that the person I trained with, John Mink, always talked about is if there is concurrent anxiety, OCD, you want to target that first and then the tics, because the OCD anxiety is often driving the tic. And I mean, obviously you're treating both of them at the same time. But if there's a really strong compulsion, it may be more the compulsion driving the tic than the primary tic, but always difficult to sort it.
Any other questions? So thank you very much, Mary, for a wonderful presentation.